All right. Hi, everybody. I am Jeffrey Vakil. I'm a joint replacement surgeon with Premier Orthopedics at Chestnut Hill Hospital. And I'm going to talk about hip and knee arthritis and your treatment options. And certainly, I'd love to welcome any comments that you may have. And I appreciate you guys for joining us and listening to what I have to say about hip and knee replacement. A little background about me. I'm a joint replacement surgeon. I went to Jefferson Medical College and I did my residency in orthopedic surgery at Drexel University College of Medicine. And then I subsequently went to Johns Hopkins for my joint replacement fellowship and have been in practice for 10 years and have a pleasure now of joining Premier Orthopedics at Chestnut Hill Hospital and bringing my joint practice to Chestnut Hill. My expertise lies in hip and knee replacement surgery. So I do what's called primary hip and knee replacement, which is if someone has hip or knee arthritis and they've failed conservative measures, which that's what I'm going to focus on today. If they fail conservative measures and they're ready for joint replacement, I'm the surgeon who will perform your joint replacement. In addition, I also perform revision surgery, which is if your implant wears out for any reason, I can replace that. And I do a number of fractures, hip fractures in many different patient populations. But again, my focus is more on joint replacement surgery, but certainly I'm willing to see general orthopedic conditions. So I'm here to talk to you about hip and knee arthritis and treatment options. And certainly, you're talking to an orthopedic surgeon, and first and foremost, everyone always thinks, oh, this joint replacement surgeon is going to railroad me right into the operating room, but that's not what we're here to do. I'm here to give you all of the options, and certainly the conservative options are a significant, a very important part of the treatment options I offer. And certainly if those conservative options fail, then we can always discuss joint replacement. But I always love to give you the conservative options first. Let me start out by telling you that joint replacements have been increasing in number over the last several years. And certainly the numbers are projected to be increasing tremendously over the next several years as our population continues to increase. And also we're doing more activities. So younger patients are actually expecting to have pain-free existence. And so we're doing joint replacements in a wide number of different patient populations. So again, we're expecting significant increases in the number of joint replacements in the future. And just to kind of tell you, joint arthritis in both the hip and knee really can be a burdensome problem for patients with those conditions. It can take you out of work and cause a lot of pain and discomfort and really take you away from the normal activities you like to do. And so, there's some conservative options that we have to offer. I'm going to start out by talking about knee arthritis. Certainly when you have knee pain, there are many things that can happen to the knee, whether it's an acute injury or an injury or pain that has been going on for some time. Typically in the patient population of 50 and above, our first thought is that you may have arthritis. But if it's an acute injury and you're an athlete, certainly we'd look at more of an athletic injury. But if it's a slow onset in pain that has gotten worse over time and you're above 50, again, not everybody above 50 has arthritis and not everybody below 50 doesn't have arthritis, but that's a general number and age that we utilize to kind of define the differences in patient populations. But basically, if the pain has been consistent over time and worsening over time, my first thought is we better work you up and find out with some history and physical examination, some tests to find out if you're developing some arthritis. So when you come into my office, the first thing I do is I get a history and find out exactly what's happened to you, how long the pain's been going on, where the pain precisely is, and what kind of pain is it. And so I will get that history, and then we'll perform a physical examination. Physical examination is extremely important in orthopedic surgery. It really helps us define exactly where your pain is coming from and where we're going to focus our attention when we are looking for a pathologic process like arthritis. So then once I perform the physical examination, I will get some x-rays. And typically, actually, I have to get the x-rays before you come into the office, so we have everything ready for you when you do come into the office. So I'll combine your history with your physical examination, and then I will also look at your x-rays, and we'll go over those. And if I had the ability to share my screen here, I would show you x-rays of a normal knee and a knee that's arthritic. Basically, the knee joint itself, and then I'll touch on hip arthritis later, but the knee joint itself is made up of the distal end of the thigh bone. That thigh bone is called the femur. It's the upper end of the tibia bone. The tibia bone's the shin bone. And then there's the kneecap. Each ends of those bones have cartilage on them. There's two types of cartilage. When we talk about arthritis, we are talking about the wearing of both types of cartilage, both meniscal cartilage and what's called articular cartilage. Articular cartilage, if you can imagine, when you eat it, if you guys like eating chicken, if you look at the end of a chicken bone and you see the white, smooth surface at the end of the chicken bone, that's the cartilage that we're talking about. That cartilage is a protective surface. It allows the bones to move smoothly upon one another. In the knee joint actually bends and extends, so that cartilage allows the bones to move smoothly upon one another as the knee bends and extends. But over time, unfortunately, so both time, previous activity levels, previous injuries can damage that cartilage. And over time, that cartilage can wear away. When that cartilage at the ends of the bones wear away, that's the simple definition of arthritis. And by x-ray, we look at x-rays, and in an x-ray, cartilage actually doesn't show up on x-ray. It shows up as a space between the ends of the bone. So when the cartilage wears away, we look at the x-ray, and when the space narrows, that means that cartilage is wearing. When the space narrows to the point where the bone touches the bone, that means, unfortunately, all the cartilage has worn, and that's what we define as bone-on-bone arthritis. That, again, can be as a result of, over time, the cartilage wearing out, weight. Excess weight certainly doesn't play a good role in protecting your cartilage. There's some genetic components also involved in the development of arthritis, but also, like I said before, injury can also predispose you to cartilage injury and the progressive symptoms that you have with arthritis. And typically those symptoms, then pain is around the knee, in the front or in the inside or outside of the knee. Sometimes it's in the back of the knee. It can extend up and down the leg. So the initial things that we recommend are rest and activity modification. So if patients come into me and say, boy, I just had a week of hard activity in the gym. Obviously, we're not doing that now. But I did a lot of Zumba, a lot of lunges. My knee hurts. Well, certainly if we define by physical examination and by x-ray that you actually have arthritis, we'll certainly start out with the most obvious treatment options. Let's take a step back and rest and modify your activities from those things that you were doing. The other thing I'd recommend is over-the-counter medication, such as Tylenol, Aleve, or Advil. Some patients who have other medical issues may not be able to take the anti-inflammatories due to the use of things like blood thinners or other medications that your doctor may say anti-inflammatories shouldn't be utilized. So Tylenol is a nice option. And there are other options of pain medication. Certainly some people come in and ask for some pretty significant pain medications like narcotics, but certainly narcotics in the long term and even in the short term are really not a good option for chronic pain from arthritis. So once you've rested, modified your activities, taken your over-the-counter medications, we always recommend low-impact exercise if we do find that you have arthritis. Running and jogging probably aren't a great thing, no question about it. Running and jogging aren't a good thing when you have arthritis because that high-impact activity will definitely cause more pain. Some people are very wonder why the next recommendation, we utilize the next recommendation, which would be physical therapy. People look at me strangely and say, well, why? I have arthritis and I have pain from a joint that's wearing out. Why in the world would I go and do physical therapy? Well, unfortunately, because of the pain, the muscles around those joints become weak. And so by sending you to physical, and the joint just doesn't function well. So by sending you to physical therapy, we're actually able to strengthen those muscles and really help to make the joint function better. So it doesn't sound like a good thing to do, but in fact, physical therapy oftentimes really helps to strengthen those muscles and really make the joint function better, despite having arthritis. And many patients with mild to moderate arthritis are very surprised when the pain gets better, even after some activity modification, over-the-counter medications, and physical therapy. So unfortunately, some patients don't get full relief from those first three conservative options. So we can always consider bracing. Certain types of arthritis, braces are more amenable to helping take pressure off of certain parts of the joint, but that's not every arthritic joint. But a brace can be given and can help with pain. Sometimes we tell you maybe you should go to the pharmacy and get a neoprene sleeve or one of those sleeves that gives you more compression and gives you some support to the knee. And oftentimes those work for patients. So then we also will recommend a cane or walker. Many times our patients don't really want to use a cane or walker because they say, well, that makes me look old. But most importantly, if you have difficulty walking because of your arthritis with a significant amount of pain, I think it's important to use a cane or walker, because the last thing you ever want to do is lose your balance because you have a lot of pain in your knee or hip. And so using a cane or walker can help you with balance and prevent falls or other injuries. So a cane or walker. Then we get into more aggressive treatment options, such as injections. There are two types of injections for knee arthritis. One is cortisone, which is a local, powerful anti-inflammatory. When injected into a knee, helps decrease inflammation and help with pain. And that's typically the first type of aggressive conservative option I would use on a patient with known arthritis. And then for the mild to moderate patients with arthritis, and even some patients with severe arthritis, will try what's called a joint lubricant. They're also referred to as visco supplements. Names of these are Synvisc, Orthovisc, Euflexa. Names are not as important as the treatment. But these visco supplements can be utilized. They're typically given in a series of 3 to 5 injections. Sometimes they're single injections. But ultimately, these can be given and can help with pain. Some people are under the impression that these grow cartilage back, they pad the ends of the bone, but they really don't. We're not exactly sure how they work, but they seem to help the joint develop a better joint fluid, but it certainly unfortunately doesn't grow cartilage back. So this is does not replace cartilage and does not pad the ends of the bone. But in some cases, people have a great outcome from them. Unfortunately, those are really the options that we have. And we always have to throw in weight loss. I think weight loss is a key component to taking pressure off of the joint. In the knee particularly, if you lose 1 pound of weight, that's worth 3 to 5 times the weight that you lose. So if you lose 20 pounds of weight, that's 100 pounds of weight off of your knee. So it's very important to consider weight loss in the treatment option as well. Well, unfortunately, if those things don't work for your knee, then we talk about surgery. But those are the options of treating knee arthritis. So I'll recount them. Number 1, over-the-counter medications. 2, activity modification. 3, we're going to throw in weight loss up there. 4, cane or walker. 5, bracing. And then certainly we get into the injections of both cortisone and the visco supplementation or gel injections. There are a couple of options. I'll quickly run through them. For knee replacements, Total knee replacement is typically what we recommend in somebody with arthritis in more than one place in your knee. If it's both on the inside and outside or all three places, even underneath the kneecap, a total knee replacement is what we recommend. And I can always talk to you about that, exactly what that means when you come and see me. Partial knee replacement can be an option, but it really is only an option in about 5% of patients. And partial knee replacement is typically performed if you have arthritis in one part of the knee. And so partial knee replacements work pretty well, but eventually, typically the other parts of the knee do wear out. That would require total knee replacement in the end. But people do well with partial knee replacements, but unfortunately, again, only about 5% of the population is really a candidate for partial knee replacement. So now that we've talked about knee replacement, if there are any comments or questions, I'd love to have those. But overall, I have to tell you, knee replacement works very, very well. It really has a 90% success rate at 15 to 20 years. So they really last 15 to 20 years, 9 out of 10 times. And they really do a nice job most of the time. Not everybody with knee replacements do perfectly, but really for the most part, a large majority of patients do well with knee replacement. So I have a question here. Dr. Vakil, we received this question, and what is cartilage restoration and who is a candidate for this procedure? Well, in knees, cartilage restoration is typically reserved for the athletic young patient with defined small areas of cartilage loss at the ends of the bones at the knee. And so really it's more of a sports doctor who would manage something like that. But certainly it's more of the younger patient. Unfortunately, if you develop a significant amount of arthritis in your knee, meaning more than one small focused area, you're really not a candidate for cartilage restoration. And again, is more reserved for the young athletic patient. So hopefully that answers your question. Let me move on to hip arthritis. To be totally honest, the treatment options for hip arthritis are really about the same as knee arthritis. The joint itself is just different. The joint itself is located up by the groin area. Oftentimes people come to me pointing to their back or their upper portion of their buttock, and they say, oh, my hip hurts, or they point to the side of their hip. In reality, where the ball and socket, and so let me give you a little definition about the hip joint itself. The hip joint is made up of the other portion of the upper portion of the thigh bone called the femur, and that femur bone or the thigh bone ends in a ball, and that ball sits in a socket. There's cartilage on the ball, there's cartilage on the inside of the socket. And basically, again, similar to the knee, that cartilage is there as a protective surface, allowing that ball to move smoothly in that socket. Unfortunately, like the knee, over time, that cartilage can wear away. And certainly, again, similar to the knee, we do a physical history and we get x-rays and we really define how much arthritis you have. I did receive another question today and I can answer that. So for knee arthritis, is there anything we can do prior to surgery to have an easier recovery? Yes, in fact, you can. So one of the things that I typically recommend is getting into some physical therapy, because certainly having arthritis causes us to be sedentary, not moving a lot, so the joints lose their motion, they lose strength, and they decondition, similar to the kind of recommendations on physical therapy. But I think physical therapy is an invaluable tool to really help to strengthen the muscles and to help improve the range of motion that may be lost from being sedentary because of the pain. So physical therapy is a nice thing to do. And in fact, weight loss always helps, because certainly having less weight is always easier for recovery. I hope I answered your question. So there's another question here. Beyond the pain and loss of mobility, is arthritis dangerous? Well, I wouldn't say it's dangerous per per se in the arthritis itself. However, certainly with regard to the pain, as I mentioned before, if the pain is pretty significant, it can result in patients losing their balance, falling, and then fracturing either their wrist or hip, and that certainly causes some major issues. The arthritis itself is not extraordinarily dangerous. However, if left unchecked over time, that can cause major joint deformity that makes it extraordinarily hard. And this is significant arthritis that's left untreated for a long time. That can lead to a lot of bone loss, and it makes my job as an orthopedic surgeon more challenging in reconstructing both the hip and knee if there's a significant amount of bone loss, because there can be some joint deformity that changes the overall alignment of the joint, and we have to recreate that in surgery, and that makes it more difficult. So dangerous, yes, if you fall because the pain is too great, but dangerous if you let it go too long. So to continue with hip arthritis, certainly just like hip or knee arthritis, both can cause stiffness, loss of motion, loss of strength, deconditioning, muscle atrophy. So similar to the knee, we always recommend over-the-counter medications. Again, Tylenol, Aleve, Advil are the ones I start with. Certainly, we can always prescribe some over-the-counter, a prescription brand anti-inflammatories that may be stronger and may give you some more relief than just your over-the-counters. But certainly we like to start with over-the-counters, just like the knee. Certainly, like I said before, rest and activity modification is always important, because if you're doing something that hurts, it's probably a good idea to stop that activity. Physical therapy, again, is really a great thing. Help strengthening those muscles that have become deconditioned, gain some more range of motion because of the loss of motion, and really help to get you on your feet and make your balance better by strengthening those joints and making them function better. And like I said before, weight loss always takes pressure off of joints, and I think that's always a great thing to do in any condition. And it's even good medically for your heart, your blood pressure, diabetes. Weight loss is always a good thing. For hip arthritis, we can always, again, consider a cane or walker. Unfortunately, there's no brace that we can utilize to take pressure off of a hip joint like we can with the knee. But certainly the cane or walker are really good things to keep balance and to make sure you are safely moving around with your hip arthritis. And then finally, there is the option to get a cortisone injection into the hip. Unlike knee arthritis, where we can give a cortisone injection or a gel injection in the office, the hip injection is more challenging because it lies in a position that's really deeper in the body, and there's some important structures like nerve and vessels that are that can be damaged if the hip injection isn't done by some sort of imaging technique like fluoroscopy or ultrasound guidance. So typically, if somebody needs a hip injection, we would send them off to one of our non-operative partners who can perform this hip injection under ultrasound, or we can send you to our radiology department who can do hip injections under fluoroscopy. Let me answer another question here. How soon after surgery are you seeing patients experience their relief of pain? So that's an interesting question, because I would tell you that recovering from hip surgery, total hip replacement surgery versus total knee replacement surgery are definitely two different surgeries. So hip surgery typically is easier to recover from. I personally perform what's called the direct anterior total hip replacement, which is a minimally invasive hip replacement that we perform an incision that's about 9 centimeters in length or 3.5 centimeters or 3.5 inches. And that's really on the front of the thigh. I split between natural muscle planes and replace your hip, not disrupting any of the normal tendons and muscular structures. And I'm able to put a hip replacement in that fashion, and people really recover very quickly with anterior hip replacement. Now, I've done over 1,000 anterior hip replacements, so not everybody recovers instantaneously, but for the most most part by 4 to 6 weeks. People are doing very, very well after anterior hip replacement. Not everyone is a candidate for anterior hip replacement. I would have to assess you. Some body types are not quite amenable for the anterior hip replacement, and we can always discuss that in the office if necessary. I'll tell you, knees are a little bit more challenging because once we put in a knee replacement, it requires a lot of work on your part in physical therapy as an outpatient to get that knee moving. And that's really the hardest part of knee replacement surgery. It is challenging from a pain perspective, and it really requires you to be motivated to get that knee moving, because if you don't, over the first 6 to 8 week period, the knee is going to get stiff with scar tissue. So it's of the utmost importance that you really get that knee moving as soon as you can, which is typically within the first couple days after surgery. But that therapy may last for up to 3 months and even up to a year. But typically we see patients at 8 weeks to 3 months doing very well after knee replacement. So knee replacement takes a little bit longer to recover from. But like I said before, 80 to 90% of patients do great after knee replacement. I would say that number for hip replacements, whether it's the anterior approach or whether it's some of the other approaches, people do really well pretty quickly and are pretty satisfied with their hip replacement. So a little bit easier to recover from hip replacement than it is knee replacement. So again, once you've gone, I'll get back to the hip. I hope I answered that question appropriately, but get back to the treatment of hip arthritis. Again, we have the conservative options, and I will recount them. Again, those treatment options start out with over-the-counter medications, rest, activity modification, physical therapy, weight loss, injections, and cane or walker. And certainly if we find that those aren't working and you do have bone-on-bone arthritis, and this also is true for the knee as well, you have bone-on-bone arthritis and nothing's working, well, that's when, again, we talk about surgery. But of course, surgery is always the last option, and we would never, ever recommend surgery right off the bat unless you have gone through some of these conservative options. And in some insurance plans, they will require you to go through some of these conservative options because the insurances want at least some, like Medicare, will want you to at least have tried at least 3 of those conservative options before they will justify payment for hip replacement or knee replacement. And I think it makes sense. Certainly, you just don't want to jump right into surgery when maybe some of these conservative options can help you and really allow you to keep your own hip or knee as long as you can. But certainly if the hip or knee pain is unbearable, you've tried these conservative options and nothing is working and it's really debilitating and you can't, life is horrible, we absolutely would really recommend hip replacement or knee replacement, again, depending on your particular situation. So that really kind of sums up the treatment options, both conservative and certainly the operative option at the being the final option. But that really sums up the conservative options for hip and knee arthritis. And certainly, in the end, certainly if none of these work and you have bone-on-bone arthritis, we're always happy to discuss all of those conservative options again. We can go through them again. But typically, if they are not working, we typically would say, hey, listen, we've tried all of these things. Unfortunately, nothing's working. And our last option here is total joint replacement. And what I tell my patients is, you'll know when you need it. I'll never tell you you need a total hip replacement. I'll tell you, wow, you've tried everything. Your arthritis is bad enough to warrant a hip or knee replacement. And then we'd give you the option of whether you want to move forward with hip or knee replacement, and that's at your convenience. It's an elective surgery, and I can't tell you what to do, but I can advise you the best as I can with my 10 years of experience and the thousands of joint replacements that I've performed and the number of surgeries that I've done. Hopefully this has helped everyone. And if there's any further questions, I'd appreciate any final questions. But at this point, I've taken up a half an hour of your time, and hopefully this was informative. And I appreciate everyone tuning in. and have a good day.